So welcome back to this third video on pleural effusions, where we're going to be talking about effusion analysis and classification. And when we talk about the pathophysiology of effusions, this is really helpful actually, because it enables us to understand why effusions form. And then if we understand why a particular or how a particular characteristic of effusion forms, we can come up with a logical list of differential diagnoses as to causes of that effusion. And when we're thinking about the formation of effusions, we're really talking about sort of Starling's forces and the factors at play there. So oncotic pressure, hydrostatic pressure, and vessel permeability at a capillary level that result in effusion formation. So transudates form due to reduced oncotic pressure, modified transudates form due to increased hydrostatic pressure, and then chyle will be increased lymphatic pressure. Exudates form due to increased vascular permeability. And then blood, as an effusion, will form either due to a coagulopathy or primary or local pathology that resulted in sort of vascular damage and rupture, essentially. So when we classify these effusions, we've said that pure transudates form due to reduced oncotic pressure. And because the force at play here is just reduced oncotic pressure, so there's less oncotic pressure holding water and other electrolytes in circulation, ultimately we get sort of leakage of a very watery and electrolyte rich, but essentially sort of a low protein, low cellularity fluid into the space where the effusion's forming. And so pure transudates by definition are low protein, low cellularity. When we think about modified transudates, we've said they form due to increased hydrostatic pressure, and therefore if we've got increased hydrostatic pressure, we're going to have slightly more pressure forcing our fluid constituents of our sort of blood out of our vessels, and so we'll end up with an increased cellularity, increased protein fluid, more than a transudate, but not quite as much as an exudate. Exudates form due to increased capillary permeability, so we have high protein, high cellularity fluids forming with exudates. And you can see these numbers that I've put in this table here, both in terms of laboratory analysis, but also sort of basic Friday night figures for specific gravity and how we classify effusions based on specific gravity. There's a huge amount of overlap in perception of where the cutoffs are and how much overlap there is between categories, and these are not absolute rules, and some patients will have multiple disease processes contributing to their effusion development, so these are certainly not hard and fast rules that we can follow on every occasion, but they can be really helpful. When we've got exudates can be sterile, so not associated with an infection, or septic, associated with an infection, classically bacterial, less commonly fungal, and hitting either the nucleated cell count requirement or the protein requirement will be enough to classify them as an exudate. So for example, classically FIP, so feline infectious peritonitis, has very commonly got really high protein, but actually relatively low cell count. Other types of exudates include sort of bile peritonitis or uroabdomen, and ultimately they result in exudates because they're very irritant to the peritoneal lining and result in sort of a widespread vasculitis in the cavity. Chyle classically is high lymphocyte rich fluid, but with chronicity we'll see more neutrophils, and we will see increased proportions of triglycerides in the fluid compared to the serum. We can see what's called pseudochyle, where we actually see increased cholesterol compared to triglycerides in the fluid as well. Blood, to classify a fluid as blood, we've got a PCV of 10% that does not clot. So these are our different effusions and how we classify them. And we're just going to chat through our approach to each effusion one by one on the following slides. So when we've got a pure transudate, we've already said these form due to reduced oncotic pressure, which in effect is hypoalbuminemia. And causes of hypoalbuminemia classically are reduced production from the liver, so hepatic dysfunction, or losses of albumin either due to a protein-losing enteropathy or protein-losing nephropathy. Other diseases can potentially cause quite marked hypoalbuminemia as well, but these ultimately are associated with really apparent other signs. So for example, blood loss, we can lose a large amount of protein, but we'll also be severely anemic, and there should be a clear sight of that. With severe burns or exudative disease, we can become hypoalbuminemic, and also albumin is an negative acute phase protein. So we'll see hypoalbuminemia with acute phase response, but it's usually mild. In order to effuse, really, we probably need an albumin of less than 15 gram per litre to result in an effusion. And so if we're wanting to evaluate for causes of a transudate, where we've got a patient with hypoalbuminemia, we're going to be wanting to evaluate their liver function with postprandial bile acids, their protein loss in the urine with urine protein creatinine ratio, and possible supporting evidence for enteric disease with a B12 folate. And then ultimately, once we've narrowed it down to an organ, we're going to want to follow up with imaging of that organ and potentially further sampling of that organ if appropriate and indicated based on what else we found. When we're thinking about a modified transudates form due to increased hydrostatic pressure in the capillaries that arises from increased downstream venous pressure. And there are some variances in this depending on the cavity, but we're primarily talking about the pleural cavity here today. So this can include organ entrapment or displacement, specifically lung lobe torsion or a diaphragmatic rupture. We could have a space-occupying lesion causing a venous obstruction. Or we could have cardiac causes, and these are a really important group of differentials, either a pericardial effusion or heart failure. If we've got a modified transudate in the abdomen, then another really big possible contributor is liver failure. So decreased hepatic compliance due to fibrosis or cirrhosis that will result in portal hypertension effusion development, and that can be associated with liver failure but is not necessarily at the beginning of that disease process. So definitely evaluate hepatic function in those patients. Another important differential in the abdomen is the use of alpha-2 agonists, which cause vasoconstriction, and we can get adjustments in vascular pressures, and ultimately we can get transient effusions forming in sedated patients who've had alpha-2 agonists. So bear that in mind if you've sedated your patient with that drug and you've got the effusion identified as a consequence of that in the abdomen, and consider that as a differential. So if we're thinking about these differentials, we're going to want to do some imaging to evaluate for space-occupying neoplastic structural disease. We're going to want to evaluate for cardiac disease and ultimately do that before we perform any sedation, so sort of echocardiography. And then we're going to want to evaluate for hepatic disease if we're talking about the abdomen. Chylous effusions we've mentioned are the same pathophysiology as transudates, but it's just a downstream lymphatic failure or obstruction. And so common thoracic differentials will be neoplasia, idiopathic, trauma, or cardiac, particularly in cats. So again, where we've got cardiac differentials on our list, performing echocardiography is going to be really valuable. But otherwise, our diagnostic pathway is going to be as for our modified transudates. Chylous effusions are rare in the abdomen, so we certainly don't want to forget them as a possibility in the abdomen, but they're not common. When we think about exudates, these arise due to increased vascular permeability. As we've said, they've got the highest level of cells and protein in. And these can either arise due to a primary vasculitis, which is rare in dogs, but we see in cats, particularly with feline infectious peritonitis, where they get a perivascular pyogranulomatous inflammation. Or we can see vasculitis secondary to marked local inflammatory disease. So for example, if we've got a septic process, a pyothorax, it's very rare to see sterile vasculitis in the chest, but in the abdomen, an example would be pancreatitis. And then neoplasia, again, can cause all types of effusions, but is on the list of causes for a sterile exudate in the chest as well. So when we're considering hemorrhagic effusions, our primary differentials are either a coagulopathy or structural disease within the thoracic cavity. Coagulopathies that result in cavity bleeds are classically secondary coagulopathies, so clotting factor deficiencies, whether they're isolated or combined, and one of the most common examples of that will be rodenticide toxicity, but we could potentially see them with primary clotting factor deficiencies as well. Or we can have primary pathology within the body cavity, so for example neoplasia, trauma, or spontaneous thymic involution is an important consideration in young dogs. So some young dogs can spontaneously involute their thymus and develop a hemothorax at the same time. And so we may see thymic remnant or an apparent thymic mass on imaging in these patients. And just to bear in mind that if they're young and they're otherwise well, and this was a peracute onset, this could be a benign disease process. So in these patients, we're going to want to evaluate for coagulopathies with a haematology including platelet count, PT evaluation, APTT evaluation, plus minus further sort of more advanced coagulation testing as indicated. Or we're going to want to image them if that's all normal to look for a primary structural disease within the chest so that we can chase that further. And it goes without saying that if we're identifying structural intrathoracic diseases where we're concerned there may be a neoplastic process, then percutaneous sampling of those, assuming patients are not coagulopathic, is going to be indicated to yield a definitive diagnosis. So in terms of laboratory submission, we're going to want to collect our pleural effusion into an EDTA tube and a plain tube, our EDTA tube for cytology, and ideally we'd make some air-dried smears as well, and these would be kept outside of the fridge so that we're not compromising the ability to interpret them at the lab the next working day. And also really important to separate any cytology submissions from any formalin, so keep them in separate packages. Not that you're particularly submitting formalin for pleural effusion analysis, but if the patient is having multiple samples submitted, make sure that you're not mixing sort of formalin containing tubes in a bag with tubes for or samples for cytology. And then we're going to want a plain sample that is going to enable biochemistry for sort of protein analysis in the effusion, potentially if applicable sort of fat analysis, so lipid, so triglyceride cholesterol analysis in the effusion. And then also we will want a separate plain tube, for example, for if we're suspicious for a bacterial process or fungal process and we want to do a culture. So usually it's sensible to have an EDTA tube, your slides, and a couple of plain tubes to enable you to keep one sterile for cultures and the other one for biochemistry. The other thing to consider is for some disease processes, so for example, if we're looking for coronavirus PCR or doing immunocytochemistry on macrophages for coronavirus, a large volume of effusion so that we've got as many macrophages as possible is helpful. So do consider submitting sort of upwards of 10 or 20 mils for some of these samples, but liaise with your lab if you're not sure. And then concurrent diagnostics that can be helpful, so things like a haematology and biochemistry you may well have done by this stage, but this can help us look into underlying diseases associated with the pathophysiology of the effusion. We may well want to do thoracic and possibly abdominal imaging, ideally post-drainage, and my personal preference if patients are stable is to drain their chest and do their thoracic imaging the following day so that they've had time for pulmonary re-expansion, and I get more information when I'm looking at the pulmonary images, whether that's on CT usually, and particularly with radiography, you'll just get more information if those lungs have had an opportunity to re-expand. And then we may want to, as we said, perform cytology of any masses that are present. Cardiac evaluation can be helpful, and if we've got a suspicion for cardiac disease, this should come right at the beginning of our ancillary diagnostics. If we have not got the ability to do cardiac assessment in-house, then learning point of care ultrasound, at least to get a subjective impression of the heart, but also things like your NT-proBNP that's got a good sensitivity and specificity for cardiac disease and can help as a differentiator, and both cats and dogs is valuable. And then sometimes we'll need to consider, as we've mentioned along the way, coagulation evaluation, testing for other endemic diseases such as Angiostronglus vasorum, which could cause coagulopathies, and a fecal smear for Angiostronglus as well, depending what country you're practicing in. Sometimes we're presented with bi- or tri-cavity effusions, and these can be really helpful to identify because this can significantly narrow our differential diagnosis list. Multisystemic diseases such as hypoalbuminemia, neoplasia, or inflammatory disease can be expected to cause effusions in multiple cavities, although sometimes can be confined to one. Cardiac disease can also cause effusions in multiple cavities, so particularly there are species differences here that are worth noting. So right-sided heart failure in dogs, whether that's due to myocardial or valvular disease, or particularly of importance in terms of its commonality, pericardial effusions, would be expected to cause an abdominal effusion as a secondary consequence. Whereas in cats with heart failure, we more commonly see, as well as pulmonary edema, left-sided heart failure and associated pleural effusions, which is something that's not typically seen in dogs due to their variations in pleural drainage. Where we've got a coagulopathy, we can certainly have bicavity effusions in these patients as well, as can we where we've had trauma or diaphragmatic incompetency. Diagnostic pitfalls we sometimes encounter in patients with pleural effusions or any effusion, but particularly for this session, pleural effusions, will be that if they've had previous antibiotics, and this can even be just a single dose of antibiotics, a previously septic exudate can appear sterile. So just be really mindful of that. I mean, ideally, we would be sampling effusions before antibiotic administration, but if a patient's had antibiotics beforehand, then just bear that in mind when you're analysing your effusion, and certainly pop a note on the submission form to the lab to make them aware. Previous steroids may mask a diagnosis of lymphoma, and that can make that particularly challenging. Again, make your lab aware if that's a limitation in your case. And sometimes it's really difficult to differentiate between reactive cells and neoplastic cells. Importantly, the absence of neoplastic cells does not exclude neoplasia. So depending on where you look in the literature, around about 60 to 65% of neoplastic effusions, the neoplasia will be identified in the cytology, which means there's a significant proportion in whom we will not identify the neoplastic cells in the effusion. And then sometimes we can find that hemorrhagic effusions can limit our ability to interpret concurrent cell presence. So once a PCV in an effusion exceeds 20%, it's been demonstrated that you might miss neoplastic cell presence there. And so in these cases, it may well be worth considering doing a Buffy-Coat examination so that you're better evaluating the nucleated cells present. Also, particularly in the presence of effusions, particularly where these are going to be sort of causing superimposition on radiographs, but also having resulted in sort of pulmonary atelectasis, we can certainly miss abnormalities, particularly in the pulmonary parenchyma on radiographs, but also CT. Hence my comment earlier about my desire to image these patients a day after their effusions drained. That's not always clinically practical or appropriate, but just to bear in mind as a consideration. Thank you so much for your time and joining us for this video. We hope to see you again on the Langford Academy soon.